Welcome everyone to Mayo Clinic Q&A. I'm Dr. Helena Gazelka. It has been a remarkable year of discoveries and medical advances at the Mayo Clinic Center for Individualized Medicine. Some of the innovations include personalized treatments for cancer and rare diseases, and the development of life-saving artificial intelligence algorithms. All of the center's efforts are driven by advanced genetic analysis and aimed at providing patients with answers, treatment options, and hope and optimism. With us today is Dr. Marina Walther-Antonio, an assistant professor in the Department of Surgery and in the Mayo Clinic Center for Individualized Medicine Microbiome program. She has a joint appointment in Obstetrics and Gynecology, and her research focuses on the role of the human microbiome in women's health, especially in gynecologic cancers. Thanks so much for being with us today.
Thank you for having me.
Well, it's wonderful to have you here. You have a wealth of interesting experience and knowledge to share with us. I'm always saying that I love to learn something new every day. So would you start by telling us, what is the microbiome and why is it important?
So the microbiome is all the microbes that live within your body and on your body. They are born with you. They stay with you for your entire life. And for the most part, they have a very important role in our health. They keep us healthy and protected from pathogens, which are really the bad microbes out there. So the importance of that is that our body has evolved to really rely on these microorganisms to support a lot of functions that are necessary. And when there's some disturbance to that, say you become ill because of something, you take antibiotics, and now certainly, this system, this balance gets disturbed. Well, now you could have a situation where you're more prone to get sicker more often because you're out of balance, your protection is kind of off the balance. And this can be hard actually to fix. It can be difficult. It can lead to chronic conditions that are very difficult to fix in the long run. So that's why it's so important for us to be aware of it, to be protective of it, and think of microbes as not only bad things, but also very, very important and good for the most part, that are really our companions through our journey. And that there's more microbe cells in our body than human cells, which is a little weird to think about. We're still humans, but we're not just humans. That's something important to retain.
I think that much of our audience will be interested and intrigued to find out that there are good bacteria, et cetera, that live with us and on us and in us, because we always think of the ones that are infectious. So that's really interesting.
Right, especially right now. Of course, we can't even hear the word microbes and viruses, and it's very scary. But yes, they are. Use the word germs has been associated forever as a bad thing. And my son also keeps saying the germs. It's like, well, when you're outside and playing in the grass, and that's good exposure. It's healthy. You acquire some new microbes that sometimes can be protective and very unlikely to cause any health issues. There are obviously, things that are very dangerous out there, but that's why we need this extra protection. It's a good thing to our health.
Well, you are specifically studying the microbiome and how it affects women's health, and particularly in relation to cancers. Can you tell us how these are connected?
Yeah, so we are starting to just grasp the surface of these things. We are starting to see, and there has been studies we published and other investigators have published at Mayo Clinic and throughout the world, showing associations. These are what we call correlations, meaning that somebody who has a cancer has a microbiome that is a little different than somebody who does not have cancer. And that can be seen right at the beginning stages of cancer, right throughout its worst part when it progresses, metastasizes, and becomes more dangerous to the patient's health. And also in resistance to treatment when we try to treat it. And we don't know if this is just a coincidence that they, just happen to be that way because of some other type of a phenomenon that is happening, or if there's actually a role that the microbiome is playing in the causation of cancer, in the progression of cancer, in the treatment resistance of cancer. Some studies have indeed proved that to be the case. For example, there's a study and pancreatic cancer that showed that bacteria, a particular bacteria, was associated with resistance to gemcitabine, which is a particular drug for pancreatic cancer treatment. And that if you treat that bacteria, you actually can resensitize the patients to the treatment. You can change their response to treatment. So there has been a few studies, and they're increasingly common. And so we are starting to think that there's a real important role that the microbiome is playing. And the importance of thinking about this is that basically we've had this elephant in the room forever and we never knew, right? And now suddenly it's like, oh, what is that elephant just standing there, or is it actually doing something? And we are seeing, yeah, most of the time it's doing something. It might be the weight of an elephant or a rabbit sometimes, but it's there, and we should really take that into account because it is there. And so bacteria in particular have a higher metabolizing capacity than our bodies. They are able to do more things than we are because they have a more diverse portfolio of metabolic activities. So any drugs and effects that are happening, they are able to get involved with that. And so we need to think about that when we think about treatments, when we think about doses that we give people, taking into account that there's something else there that is also manipulating that drug, that compound.
I've always been astounded when I see new studies come out that, wow, someone thought to look at those two things in conjunction to one another. It's just amazing. Your most recent research is focused on endometrial cancer, which is the fourth most common cancer in women. What can you tell us about endometrial cancer?
So endometrial cancer is a cancer in the endometrium, which is the internal layer of the uterus in women. And it's not a very well-known cancer, I think, despite what you just said, which is the fourth most common cancer in women. It's also the most common gynecologic cancer. It's more common in the US than cervical cancer, ovarian cancer, for example. It is a cancer that is, it's more common than leukemia. It kills more people than melanoma, and yet, it's hard to understand why it is that people don't talk as much about that. My take is that it probably has to do with privacy, and people don't want to talk about that. It's a cancer in the reproductive system that often leads to hysterectomy, which is the removal of the uterus as a whole, often with ovaries, fallopian tubes, the cervix, even the upper part of the vagina. And people just are not comfortable speaking about these things. They might say, I have a cancer in my belly or my, whatever, that area. They don't want to specify. And so people are not as aware, I think, as they could be, that it is a common thing that they should be aware, particularly women who are, entering postmenopausal age, which is when the incidence tends to be most common. And I'm sure, women who go to the gynecologist often are told by their gynecologist, but any type of bleeding that they start experiencing after menopause, which shouldn't happen, is a warning sign for the potential development of endometrial cancer. And so they should all see their physician immediately. And there's many reasons why women could experience bleeding. So it's not necessarily, you definitely have cancer, but you should just be screened at that point. And so that's something that women need to be aware, in particular if they have other risk factors such as obesity. It is a fairly treatable cancer if it's caught early. So it's important to be caught early so that, you can go on with your life and have a healthy and long life after that. But it's important that it's caught early. When caught late, as in many cancers, it's much more difficult to treat.
So I think because this isn't much spoken about or discussed, that women might not know what to look for and what the signs and symptoms are. You mentioned postmenopausal bleeding. Are there other things that can it happen before menopause? And are there other indications that someone might want to see their doctor about this concern?
It can happen before menopause. It's not as common by far, but bleeding, also excessive bleeding, abnormal bleeding that is not your common. Women kind of learn their own cycles, and if they notice a disruption in the amount of bleeding or cycles, that's something to mention. Of course, it's more likely to be of some other cause rather than endometrial cancer, but sometimes, unfortunately, it is. So having that checked. Being a black woman is definitely a risk factor for having a more aggressive type, perhaps, of endometrial cancer. They tend to be diagnosed also later. The symptomatology can be a little different. Black women tend to have a higher propensity of fibroids, which lead to bleeding, and them kind of dismissing potentially those symptoms as, oh, it's probably just my fibroid. Physicians may be also more likely to dismiss those as well. So it's important that they insist with their physician that I want to be checked. I want to make sure this is not something worse and that they should be screened for that. Other than that are things that unfortunately are fairly common to women. It would be kind of feeling pressure, discomfort in the abdomen, which, most women do experience often. And so it's hard, it's kind of a diffuse symptom to know what could be causing it. But women who who reach postmenopausal age, who haven't had any kids, so no pregnancies, those tend to be also a little increased risk because of the number of cycles they have been through their life. So those are things to kind of just have in your mind. And again, it is a cancer that is very treatable if caught early. So that's something that people should hold on to, that it's worth kind of getting checked and taking care of it when it can be taken care of fairly well.
It seems that the incidence rates of endometrial cancer are rising. Why would that be?
Thought is that it has to do with increased rates of obesity. So obesity is the main risk factor for the disease. Also the aging of the population. We have more postmenopausal women than we ever had. And so it's just a numbers game. It's epidemiological, is thought. There could be other factors. We know estrogen can play a role as well. And opposed estrogen therapies, which are not really done anymore because of that same reason. But I think the main reasons are epidemiological and have to do with just the population. Diabetes, obesity, all of those tend to increase your risk factors as a whole, as a group.
Your research focuses on certain risk factors, such as being postmenopausal. Can you tell us a little bit about your study and how menopause is related?
Yeah, so we looked at risk factors in women who had benign, surgery, the same type of surgery, hysterectomy, removal of the uterus, but for other reasons benign. And we were interested in seeing how they compare to those same people that had cancer, and obese women who were postmenopausal. And vaginal pH was another thing we looked, that there's some women who have a higher vaginal pH. And what we saw is that most of those factors do impact the microbiome, more or less. It changes, as you would expect. But what we saw with postmenopause in particular is that it changes the microbiome in a way that looks more like cancer than, say, obesity even, which was interesting. I don't know if it was, I didn't necessarily expect it, but that's what we saw. And we call it the endometrial cancer biome. Meaning that, the way we think about this is kind of like an ecosystem, right? A human body ecosystem. And that when you think about a system, for example, dunes on a beach, and say you want to plant a tree, you can't just go there into the sand and plant, you can, but put tree seeds in the sand, you can do that, but most likely you're not going to get a tree out of that. It's not going to happen. So what typically has to happen is that has to be some kind of grass, weeds that go into there, kind of prepare the soil for what then can sustain the growth of a tree. And this endometrial cancer biome is what we call that grass. So these women don't have cancer, but it starts to look like a microbiome that will allow the thriving of bacteria that then can be more involved in those carcinogenic processes. So they have this grass, they have these weeds that is preparing the soil for something maybe not as good as it could.
Tell us about the screening tool that you developed for endometrial cancer.
That one is based on that second, talking about this ecosystem kind of analogy, is a test for a particular microbe, and it's one microbe that second hit that tree. It's the tree. That we see very associated with endometrial cancer. We see that we tested in a blind manner the presence of that microbe in the vagina of women who have cancer versus not. And we saw that it has a positive predictive value of 86%, meaning if you have that bacteria in your vagina, and this is Pheromonas somare is the name. But if you have it and you're postmenopausal, there's an 86% chance that you do have endometrial cancer. So, which would be nice thinking into the future that that's a lot better than an endometrial biopsy. I never had it, fortunately, but I hear it's not pleasant, and it's a lot of pain. And so if you can avoid that and just even self-sample, that would be much, much easier. People maybe would be more likely to do it, and wouldn't have to suffer through it so much. So that's kind of what we are thinking, and particularly for what's called type 2 endometrial cancer, which is more aggressive. It's the type of cancer has less symptoms. It's more common in Black women as well. So that could be something that would help that population in particular try to detect it early so that it's in a treatable stage. Mm-hmm.
Your recent research indicates that there may be an opportunity for intervention months or even a year prior to the development of endometrial cancer. How did you make that discovery?
That is part of a parallel study that we did in epigenetics, and in this case was methylation. Epigenetics is it's modifications to our DNA. I think of it, my analogy to epigenetics and methylation is kind of like a car engine, right? So you imagine your pedals, your brakes, and your accelerator are your genes, and your epigenetics or methylation is your ignition. So you can push your pedals and as much as you want. If the engine is not on, it's not going to do anything to it, right? So the gene has to be on or off, and that's what methylation does. You can turn it off or on, even though you don't have any mutations. People are not familiar with DNA mutations. If the gene is not active, it doesn't actually matter. So what we did was to look, and this has been studied by others, including at Mayo Clinic. Jamie Backham-Gammas has been one of the pioneers on that, and she was also a co-author in our paper. But looking into women who, Mayo, of course, has something unique, which is, we have so many patients that have been with us for so long, we can go back and see where they were 10 years ago. And women who've had biopsies back then. And what we did is a study of women who didn't have cancer at the time, and we had the biopsies, but then developed cancer in the future. And this was a period of up to 9 years, and within months to 9 years. And then women who were matched in age, BMI, all those things, but that did not develop cancer, so that we see what was different. Could we have gone back then when they had that benign biopsy that and know which ones of them were going to develop cancer in the future, because we really want to save those. And we do know that 1 in 4 women who have endometrial cancer have had a benign biopsy in the past, meaning there's an opportunity to find them and really avoid that altogether. So that's, and the average time frame that we saw was about a year that we could distinguish features. And those features were those genes on and or off, and for them. We already see them, those genes already turned off a year before they develop cancer, which is a signature of cancer already kind of starting, probably, even though it's not obvious, it's not identifiable, it's already in that direction. And we probably should be thinking about intervening at that stage and doing something, either at the very least, I would say, and more closely follow up to those women that are on that path, or even try to modify it, try to intervene. And we have grants now that we have submitted, and in thinking about following some women for 3 years and seeing the course of events, who's the chicken and who's the egg, basically, because we suspect that the microbiome and epigenetics are connected, we and others, a lot of people. We just don't know how exactly that relationship happens, and what's the best way to intervene? How can we stop this? And in my mind, thinking, if it's something that is microbiome related, you can think that it's a lot easier to intervene on your microbiome than it is on you, right? If we have a drug or some kind of intervention that's going to target the microbe, it's less aggressive than if you're targeting the patient genes or the patient directly. So I think there's great hope for good therapies that could be, very helpful to patients and not as detrimental to their health, hopefully.
You also study cervical and ovarian cancers. What have you learned about those diseases?
Our hope was that to try to find something like this, like we found for endometrial cancer, bacteria, maybe a vaginal marker that would be perfect for ovarian cancer. We looked, and unfortunately, we so far haven't found anything like that, which is unfortunate. But we did find, and are starting to find, and put together a manuscript on this, but we are starting to find potential role for treatment resistance. There seems to be some different signatures in women that end up responding or not responding to treatment. And so there could be something we could try to do about treatment, at least, even if not detection. So that's where we are in ovarian cancer. Cervical cancer, it's a kind of different project. It's something we have developed for the original idea was the Democratic Republic of Congo, with a humanitarian type of streak in thinking about giving women the capacity to test themselves for high-risk viral strains that are known to cause cervical cancer, HPV, human papillomavirus. And this is a project that we are developing now for other targets and even for US women, because when we talked about this idea here, people came back to us and said, well, why not here? Who wants to pap smear anyway? And I was like, well, that's a good point. I don't think anybody enjoys that experience. So that would be something that could, potentially in theory substitute something like that. It would be just a vaginal, or a urine test even, is what we're trying to develop. So you would just basically pee in a cup and dip a stick in it, and then it kind of changes color, not like a pregnancy test. If you have it, turns blue, and so it would be an easier way for you to do at home in your privacy, and kind of not having to go through that pap smear. So anyway, those are things that we are thinking and testing at this point.
Marina, you have a really interesting educational background, including experiences with NASA. How has your work as an astrobiologist affected the research that you do today?
That's something I started as an undergraduate doing astrobiology research, think Mars missions and green men and all kinds of things. Really interested in all that, and continue to be and be involved in those efforts. They really help each other, and I've made many jumps back and forth in technology development. Things that you use to try to detect life in other planets are not that different from trying to detect rare biomarkers in humans. It's the former Department of Chair of Surgery, Heidi Nelson, when she recruited me, she said, "You're coming here to look for life in aliens in our body. It's kind of the same." And I thought, it kind of is, kind of like that. So it's the technology is also actually not that different as you might think. Also thinking of complex environments that we don't understand yet in the entire complexity, the entire system, the links. It's also fairly similar, trying to get a systems approach to how we think about these things rather than a very narrow point of view. In astrobiology, you have to have that because it's not our planet. It's another planet that we don't know well. We've never been there. And when you think about your human body is also kind of projecting a little bit in the future. And I'm interested in cancer prevention in particular. I need to understand, why is it that you are going to develop cancer, somebody else isn't? And there's so many complex factors that go into that, that you need to take them into account. It's not going to be a one thing. If it was, it would have been solved a long time ago, right? We all know that. There's many intelligent people that have dedicated their lives to this. It's a very complicated problem that needs to be thought out as a whole, probably.
We'll get a chance to learn more about your work at the upcoming virtual conference for the Center for Individualized Medicine, annual conference on October the 14th. Tell us a little about that.
Yeah, so in that conference, we are going to speak about, kind of this idea of thinking of treating the patient, I guess, and understanding the patient rather than the disease, right? You're more than your disease. Your disease is just a little part of you. And we can defeat the disease very easily, right? The problem is keeping the patient alive and well. That's actually the difficult part, and that's the important part. And that's how we want to think about it, and thinking along the lines of individualized medicine, in that we all know that cancer treatments currently, they help a lot of people, but there's large proportions of people that are not helped by the therapies because they don't respond to them. Other people respond, but there's toxic effects to them that are sometimes even worse than the cure, unfortunately, and everything in between. What we want to understand, and this, again, going back to astrobiology, is not that different, because when we're thinking about, say, astronaut health, it's not going to help NASA if I figure out a way to keep person alive in space. What I need to keep is this astronaut alive in space, right? This person right in front of me. So I need to understand this person and what they need to stay alive in space and well. And so this is the same thing for patients. It doesn't help me to, necessarily to help a hypothetical person, an average person that often doesn't exist. It's just a construction of mind, right? But keeping you alive and is a different question, and understanding what's been your trajectory. Who are you now? Where are you going? And what can we do to put you on a path that is healthy for you, which might be different from somebody else's. But that's what matters to you, right? It's your path. And that's how we need to start thinking about these things, I think. It's just one person at a time, and really curing one person at a time. I think that might be what it takes to defeat cancer, is to have that mindset.
What a wonderful approach. I've never met two patients who had exactly the same experience. Who is the intended audience of the conference?
Physicians, nurses, scientists, general public, if they feel so inclined. I think there's room for everybody.
Our thanks to Dr. Marina Walther-Antonio for being with us to share her research with us today. And thanks to you too for listening in today. We hope you learned something. I know I did. We wish you a wonderful day.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu. Thanks for listening, and be well.